The 2014 Fine Awards for Teamwork Excellence in Healthcare. Bronze winner, St. Vincent Health Center. Improving safe use of opioid therapy.
Mrs. Smith? Mrs. Smith? My name's Debbie. I'm going to be your nurse. Mrs. Smith? Oh, when did she have narcotic last? Oh, looks like about 45 minutes ago. Mrs. Smith? I'm going to go get some Narcan.
A patient who has opioid toxicity, there are a couple main symptoms of that. One of those is a decreased respiratory rate.
Mrs. Smith, I'm going to give some Narcan here. This is going to help wake yourself up.
And the other one is sedation, sometimes to the point of, being difficult for the patient to be woken up.
Oh, there you go. Are you able to get your eyes open for me?
As part of our ongoing quality improvement process, we did an evaluation of all patients that received naloxone as a marker for patients who had opioid toxicity.
What are we giving them?
Currently we have Dilaudid ordered. I gave a dose of 1.5 about 45 minutes ago.
And we realized that nurses and patients were all having different interpretations of what was severe, moderate, or mild pain, and we had dosing errors. And you didn't get any relief?
A little bit, but not
much, huh?
Not much.
But it was a combination of the way the regimens were being written in addition to the risk factors the patients had that probably contributed to them having problems. We wanted to address the PCA order set as part of ongoing improvement of our quality and patient safety.
It would make sense to me to really develop something that's going to help prescribers identify certain risks, and then they can stratify that when they're prescribing it, and then therefore reduce the risk and put the patient on the best regimen that's going to treat their pain, but prevent any side effects too.
Certainly change is difficult for any organization, especially with processes that have been in place for a long time. But once we had a few early physician adopters, one of those being Dr. Scott Bedwell, certainly that helps in terms of changing the attitudes and habits of prescribers.
This was something that was really championed by our pharmacy team. They picked up and recognized that we were not adequately covering pain. We knew it as physicians. We were putting a lot of the onus on the nurses.
The adult pain order set was developed as a result of some feedback we got from the Joint Commission. So we developed that to limit the number of options for the nurse and to give the nurse much more guidance. With the help of newsletters and nursing managers and leaders and nurse educators, we were able to reach all the nurses and really educate them in the new process as well. If we looked at all patients on PCA who needed naloxone, our baseline rate was about 2.5%. A year after implementing the order set, that was down to 0.6%. So by providing the nurse more guidance on what agent to administer at which level of pain, it's more clear for the nurse and safer for the patient.